Okay, good morning again. It is truly an honor and a privilege to be here, and I want to thank you and Rob for the kind invitation. So the outline of my talk, I'm going to speak a little bit about the classifications of intestinal metaplasia, some data about supporting the subtyping of intestinal metaplasia for clinical practice, and some caveats on terminology and gastric cancer risk classification systems. So we have seen during several talks the Correa cascade, that this was described in the 1970s. I am going to focus mainly in the intestinal metaplasia complete and incomplete types. And first I wanted to make a parenthesis because last time that I was here in 2020, we talked about this, that Dr. Correa described that this cascade was primarily associated with the intestinal type of gastric cancer. But we see that in the presence of intestinal metaplasia is not only limited to intestinal, but there is a big percentage of diffuse type cancers that are associated with intestinal metaplasia. So this is just to show a case of a diffuse type. These are cells invading the stroma, and there are surrounding islands of intestinal metaplasia. On this topic, Rob conducted a nice study, compiling all the evidence, and he found pooled odds ratios of 2 for the association between atrophic gastritis or intestinal metaplasia and diffuse type gastric cancer. They also found that with using Olga and Olgim, studies that had Olga and Olgim reported, also pooled odds ratios of about 2 between Olga or Olgim stages 3 and 4 versus 1 and 2, and they found this also associated with diffuse type cancer. So the progression to gastric cancer for individuals with intestinal metaplasia has been studied in multiple times. There is a big nationwide study in the Netherlands, and they found a progression to cancer about 0.25% per year. The AGA technical review showed a pooled incidence rate of 12.4 per 10,000 person years. And our smaller study in the Colombian cohort, we found surprisingly a similar rate of progression to gastric cancer of 0.14 per 100 person years. About the intestinal metaplasia subtypes, one of the main classifications that has been used more frequently recognizes 2 types, the complete and the incomplete type. In the complete type, or called also small intestinal, the main characteristics are these big goblet cells that are very well developed, and they are separated by lines of enterocytes, which are these eosinophilic cells with brush border. You can see here the brush border in this magnification. And also very important are the Paneth cells at the base of the glands. For the incomplete type, that is also called colonic, the goblet cells show smaller sizes, but variable sizes, and they are separated by these other columnar epithelium with mucin droplets of variable sizes. In the colonic type, there's absent or just scarce. Occasionally, you can see Paneth cells, but they're not like this in this amount. And also, there's no brush border. The incomplete type is the one that has been associated more frequently with progression to cancer. These are 2 other examples of complete and incomplete types. In the complete type, as I mentioned before, you can see here the same characteristics, but I was showing this lower magnification because there is another characteristic, and it's the architecture of the glands or the crypts. So in the complete type, you can see crypts that are more or less straight or a little curved. But in the incomplete type, sometimes you see this architecture that is very distorted with irregular branching glands like this one. So I wanted to mention that because this is one of the important characteristics. Usually this is very well organized. The nuclei are very aligned. But when you see these other type sometimes reminds you of the dysplastic changes. Oh, another thing that I wanted to mention in this part is that these big goblet cells and the brush border, it should be expected only in the upper half of the mucosa or the 2/3, because if you look at the base of the glands, of course, you won't find those characteristics. Another classification is the one that was developed by Felipe and Jas, and this recognizes 3 types. Type 1 corresponds to the complete type, and types 2 and 3 are incomplete. For this classification, special stains are required. So one of them is the Alcian blue pass, and the other one is the hyaron-diamine Alcian blue. With the Alcian blue pass, we can differentiate from acid mucins that are in the intestine from neutral mucins, which are normal in the stomach. So in the type 1, only goblet cells will be stained for intestinal mucins. And here are some, I'm just showing with asterisks, few islands of normal gastric epithelium remaining. This staining, the Alcian blue pass, is not good to make any difference between the types 2 and 3. For these 2 types, you can see mixed intestinal and gastric mucins in goblet cells and in columnar cells, in the intermediate columnar cells. The other staining is the hyaron-diamine Alcian blue. And with this staining, you can differentiate between sialomucins and sulfomucins. So these are magnification pictures of the same cases, just to show the differences. So in the type 1, only goblet cells will show sialomucins. You can see occasionally sulfomucins, and that doesn't mean that it's higher than type 1, but only in the goblet cells. In the type 2, the sialomucins are observed in goblet cells, but also in these columnar cells. And the type 3 is characterized by this brown staining, which means there are sulfomucins. So among the incomplete type, the type 3 is the one that is associated more frequently with progression to cancer. So what do we do with all of this for clinical practice? Really nothing, because this technique has been abandoned a long time ago because it's first of all, it's very technically challenging. We have a great histotechnologist, so he's amazing. He's been doing this for a long time. But this has been discontinued also because these require the use of some very toxic compounds. Going back to basics, which I like the most, these are just plain H&E. So if you have a good biopsy, good size, well-oriented, and a perfect section, this is all you need to classify complete versus incomplete. So in this case, sorry. Okay, so I will go back to this case, but first of all, I wanted to show some data about the intestinal metaplasia subtyping. So this is the AGA technical review, which recently found a relative risk for incident gastric cancer in incomplete versus complete of 3.3, supporting the subtyping. In our Colombian cohort, this is a paper that we recently published for our Colombian cohort, which is the follow-up of 20 years, during 20 years of individuals with gastric precancerous lesions. And I wanted to show a few data related with the incomplete versus complete. So we found these are individuals that had biopsies at baseline and 20 years. And we found that the incomplete showed greater progression to low-grade, high-grade dysplasia at 20 years or gastric cancer at any time than the complete metaplasia. So these were individuals that had intestinal metaplasia or indefinite for dysplasia at baseline. So what we found is that for those, the percentage of progression to more advanced lesions for complete and incomplete were respectively 2% versus 18%. I wanted to make a parenthesis to talk about the indefinite for dysplasia diagnosis, because it's something that sometimes is difficult to understand for clinicians. This is like a borderline lesion between metaplasia and dysplasia. And what we mean is that these are cases of intestinal metaplasia, but start to show some characteristics of dysplasia. They're not overt dysplasias yet, but they have some bigger nuclei, like a little hyperchromatic, or this branching of the crypts. Sometimes hyperproliferation of the crypts with back-to-back glands. So these are like those lesions that you're not completely happy just to say, no, just metaplasia. But they're not dysplasias yet. So this is what we mean with indefinite for dysplasia. Going back to the Colombian cohort, we found that in individuals that had intestinal metaplasia or indefinite for dysplasia at baseline and at 20 years, biopsies at baseline and 20 years, 2/3 of those that had complete metaplasia at baseline showed a change to incomplete in the biopsies at 20 years, while only 17% of those that had incomplete regress, we could say regress, but not really, but showed a change to complete metaplasia at 20 years. So these findings support other findings that makes us think that really first is complete and then progresses to incomplete. So the incomplete is a more advanced stage of intestinal metaplasia. The rates of progression to gastric cancer by intestinal metaplasia subtype at baseline were 0.028 and 0.37 per 100 person years for complete or for incomplete metaplasia. And the risk of progression to gastric cancer for those with incomplete versus complete was 13 times higher. We also found that the incomplete metaplasia was associated with increasing Olga and Olgin stages. This is evaluation of Olga and Olgin at baseline biopsies. So we found that there was an increase, a significant increase. So this also supports that the incomplete metaplasia, in cases that you don't have enough biopsies to really stage the Olga or the Olgin with the Olga-Olgin systems, you can use the incomplete or complete type as a surrogate, or the incomplete type as a surrogate for extensive metaplasia. Going back to this case that I wanted to show you, this is one case that I wanted to show what we mean with mixed metaplasia. So I made this to separate. On the left, you can see that all of this is normal gastric glands, normal gastric epithelium. Here is one metaplastic gland. There is no area of non-metaplastic, and then you can see one incomplete, then complete, then incomplete. So really, not always is like the pictures that I showed at the beginning that is complete or incomplete. Many cases, and probably most of the incomplete are mixed. Here is a higher magnification to show this the same. Here you can even see the brush border in the higher magnification with this eosinophilic border, and some crypts that don't show Paneth cells and other ones that do show Paneth cells. So this is really a mixed case. So I prefer the H&E, and I think that most cases can be classified in H&E, but also there is this nice staining that you sometimes can use to differentiate or to highlight the presence of acid mucins in the stomach. So I'm going to show you just how it looks with the complete metaplasia. Only shows these acid mucins blue in the goblet cells. The columnar cells shouldn't show any staining. And these are 3 foci of that metaplasia. There is one case of incomplete metaplasia. The normal gastric epithelium with staining stains pink. And the incomplete metaplasia shows a mixture of acid mucins blue and then the gastric mucins in pink. And then this is a case of mixed intestinal metaplasia. There is a crypt here with incomplete intestinal metaplasia characterized by this mixture of pink and blue mucins, and this is surrounded by other crypts with just complete metaplasia, all around it. Some authors have suggested the use of CD10 as a marker for complete metaplasia because this stains the brush border. And in this study, they found that it was a marker that with good sensitivity, specificity, and positive and negative predictive values for the diagnosis of complete metaplasia. Here are some images showing a case of complete metaplasia with the nice brush border stained in brown, and a case of incomplete metaplasia without staining. Now I wanted to highlight some caveats on the terminology and gastric cancer risk classification systems. I mentioned this last time also. For those that are not familiar with the Olga and Olgin staging systems, they were developed based on the evidence that the extent of histological atrophy or metaplasia correlates with the risk of gastric cancer stages. And these systems are supported by multiple international guidelines for the identification of individuals that are at higher risk and may benefit from endoscopic follow-up. 5 biopsies are required for these systems, 2 from the corpus, 3 from the antrum, including 1 on the incisura, and then should be submitted for pathology in separate jars. The Olga, one important thing that is difficult to understand for many is that the Olga staging system, the atrophy in Olga means any type of atrophy. So non-metaplastic atrophy, intestinal metaplasia, and pseudopyloric metaplasia. The extension of all of these lesions is what makes the Olga system. And the stages 0 to 2 are considered low risk, and the 3 to 4 are considered high risk. The Olgin system is a similar system, but only assesses the extent of intestinal metaplasia, and was proposed based on better inter-observer agreement than the Olga. The stages are the same, but one important thing to mention is that the Olgin stage can never be higher than the Olga stage, because the Olga includes intestinal metaplasia too. Another point that I wanted to mention about is the classification of extensive versus limited. So the AGA technical review found a relative risk of incident gastric cancer in extensive versus limited metaplasia of 2, based on only 2 studies. And the definition of extensive metaplasia is when it involves at least the corpus, regardless of antral or incisura involvement. Unlimited is defined as involving only antrum or incisura. But there is some caveat with this classification. Today, intestinal metaplasia limited to the antral compartment is considered a low risk by some guidelines, including MAPS-2, the AGA, and the British Society of Gastroenterology, which makes me think that maybe it's not the best way to classify the risk, because you can have limited intestinal metaplasia that includes some Olgin stage 3. Here is an hypothetical example of a patient with 3 antral biopsies and 2 corpus biopsies. And you can have intestinal metaplasia in more than 60% in all antral biopsies, which means a score of 3. And this means a stage 3, even in absence of any lesions in the corpus. So we need to think about what we call limited versus extensive. Of course, these are extreme examples, but they could happen. So this would be considered under this definition. This would be considered limited, individuals with all the antrum metaplastic, versus extensive focal area of intestinal metaplasia in the corpus. The other caveat, and I commented this last time, is that the extensive metaplasia, you can have even all biopsies with intestinal metaplasia and still be a low-risk Olgin. If you have up to 60% of metaplasia, the average up to 60 means a score of 2 for the antrum. And if you have 2 biopsies on the corpus with up to 30%, will be score 1. So if you combine here, this patient will be stage 2, considered low risk, which probably won't be the best classification. So take-home messages are, first, the intestinal metaplasia classification into complete and complete types should be performed preferably in H&E. Of course, optimal conditions are required. For a diagnosis of complete metaplasia, the following characteristics should be present. First, well-developed goblet cells, well-defined brush border in the foveolar mucosa, approximately half or 2 upper halves of the mucosa, and Paneth cells at the base of the crypts. A staining with Alcian blue pus at 2.5, at pH 2.5 may be useful to highlight intestinal or gastric mucins in columnar cells of the incomplete type. And I brought this because I didn't bring, I didn't find a good case to show, but sometimes the H. pylori shows some vacuolization of the epithelium. And when you see that vacuolated cells, sometimes it's difficult to figure out if it's actually incomplete metaplasia or it's just the vacuolization due to H. pylori. So this is a good staining to differentiate between acid mucins. If you stain and find some blue staining in those cells, that's intestinal metaplasia, and if it's pink, it's just gastric mucins. So any special stain used for intestinal metaplasia subtyping should be used to complement the assessment in the H&E and not to replace it. And finally, the surveillance in individuals with intestinal metaplasia limited to the antrum or with low-risk Olgin stages should be individualized. And these are my acknowledgements, and thank you for your attention.